Welcome to the Head and Neck Cancer 2020 video series, presented by St Vincent's Hospital Sydney, the Kinghorn Cancer Centre and St Vincent's Private Hospital Sydney. Innovations in Radiation Therapy with Associate Professor Dion Forstner.
Hello, my name's Julie McCrossin, and it's my pleasure to welcome you to this video on innovations in radiation therapy for head and neck cancer patients. And it's one of a series of videos all about innovations to improve quality of life and to improve survival. And these videos are hosted by St Vincent's Hospital Sydney and the Kinghorn Cancer Centre. As I said, my name's Julie, and 7 years ago I was treated for stage 4 oropharyngeal cancer, and that's a cancer in my tonsils, tongue and throat, and that's an example of a head and neck cancer. And I'm here today. I was treated with radiation and chemo. Our purpose is to raise awareness about head and neck cancer and also to give you high quality evidence-based information. And I'd like to acknowledge that we're broadcasting to you today on Aboriginal land, the land of the Gadigal people of the Eora Nation, and to pay my respects to elders past and present and to emerging leaders. And I want to acknowledge that Aboriginal people and some Torres Strait Islander people are disproportionately affected by the head and neck cancers that we're talking about in this video. So our focus is radiation therapy, and I've got a radiation oncologist, a dietitian and a speech pathologist, and we'll tell you about what's the good news about what's improving our survival and lessening the side effects, and also what's on the horizon.
Hi, I'm Hans Eid from Camden, south of Sydney. In 2011 and 2013 I had surgeries and extensive radiations to my throat. To all the surgeons and oncologists and nurses, to you I'm forever grateful, and thank you for saving my life and making me a survivor beyond 5. But 3 years ago my body started to break up and I had problems. So my question to the panel is there such a thing today, or is it any plans to introduce a multidisciplinary team for after the treatment for patients with complications to help them to have quality of life, not just to survive, but the quality of life is important. And I would hope, if that's the case, we can go from, instead of being beyond 5 to beyond 10. Thank you.
So let's begin with a radiation oncologist. So Dion, welcome. Can you introduce yourself and explain a little bit about your history looking after head and neck cancer patients like me and what your job is now?
Well, I've been working in the area of head and neck cancer management for the last 17 years as a radiation oncologist. And I've worked in various parts of Sydney and I did my training in South Australia, and I hail from Tasmania. So recognise that there are lots of differences for patients, whether they come from a large metropolitan area or from regional areas and face enormous challenges. Or in the days I trained in South Australia, there was no radiotherapy in the Northern Territory, so patients flying thousands of kilometres to have their treatment.
And it's fair to say that in terms of challenges faced by patients and family, access for rural and remote and some outer suburban people in Australia and New Zealand can still be an issue?
Absolutely, and especially in an area like head and neck cancer, which isn't one of the really common cancers. And so management is very complex and very multidisciplinary. This cancer cannot be managed in isolation by a single clinician. It must have multidisciplinary management of these cancers. And so accessing that from a regional or remote area is a real challenge and causes a lot of stress for patients and their carers in particular.
I want to hear from you what you see as the absolute key messages when it comes to innovations that are improving survival and quality of life, particularly obviously on radiation therapy. And as I understand it, you believe that getting the right treatment to the right patient is critical, and that is only possible with a multidisciplinary team where the team members have got specialist experience with head and neck cancer patients. Can you explain what all that means and why it matters?
These cancers are not the most common cancers. They're in a very challenging area for people, and function is hugely important. So
everybody talks about function. What is this function?
Well, we want people to be able to talk and well, to be able to eat well, to be able to communicate well. Obviously, it's much more than just speech, and they're the things that we can have an enormous impact on. And sometimes we do, because the cancer's advanced and we can't avoid that. But we want to make sure that we're giving the patients the best chance of cure with the best function in terms of outcome. And we have to weigh those things up. And no one of us can really make that decision. It needs to be made where there's discussion between a radiation oncologist, a head and neck surgeon, speech pathologist, dietitian, nurses, palliative care physicians sometimes, with support from the radiologists and pathologists.
And medical oncologists, the chemo people?
Absolutely. And only when we have all those people in the room can we really come to, I think, form the right decision for that patient. Not always, the patient doesn't always have to be there, and in some cases they will be, but they obviously need to have been well assessed and the information about that patient brought to that meeting for discussion. Now, there are some very early cancers, very small cancer on the tongue may be one, or on the gum may be one that can be dealt with by the surgeon. But the majority of cancers should be discussed in a multidisciplinary team setting.
Okay, and can I ask you, because our focus is on innovations in radiation therapy, is the use of a multidisciplinary team an innovation? And if so, what improvements have you seen for the patient as a result of that? Like, how long have these teams been about, and does everybody have access to one?
Well, pleasingly, Julie, these teams have actually been about for a long time. And in fact, in head and neck cancer, they're really, in most institutions, they'd be the most long-standing multidisciplinary team. And they often function actually much more cohesively than other multidisciplinary teams, partly because they've been around for so long. But it's very important that each of us that attend those meetings brings the innovations in our area to those meetings to be weighing up the pros and cons with, new techniques. Can we offer a better outcome with non-surgical management versus surgical, or the other way around? Or how do we actually combine an innovation, whether it's a change in some sort of therapy, or a new surgical technique and so on. But we can only really do that because this is multidisciplinary. It requires often more than just that one modality if we're making sure we're bringing those innovations in a very coordinated way.
Let's turn now then to the innovations in your particular area of expertise, which is radiation therapy, because you're a radiation oncologist. I want to hear from you, what are the key innovations in that area that are good for the head and neck cancer patient? And for people watching this who've never seen a bunker where we're standing now, what is this room? And illustrate what you're going to say by showing us where it happens.
Well, maybe I'll start by telling you about this machine, Julie. So this is a linear accelerator, or a Linac, and this is the radiation treatment machine. So the powerful X-rays come out of here and then go into the patient. This machine, the X-rays are just like X-rays that people have for when they're having a chest X-ray or a CT scan, except they're more powerful. They don't feel anything while they're having them. And then whilst the X-rays are coming out of here, the machine is rotating round. And that allows us to very accurately deliver the high dose to the area that needs to be delivered. That's the tumour. And to provide or to ensure that there's a much lower dose to the surrounding areas. And that's really the thing that over the past decade and a half has changed a lot in radiation therapy, where we can avoid those very important structures that are so important for function that aren't involved by the cancer. We want to keep the dose as low as possible.
And is that on things like salivary glands or the bone where our teeth is? Tell us what you're trying to miss.
In past times, radiotherapy caused people to have long-term severe dry mouth. Now, they still get a dry mouth, but in most people that's temporary, but still some will get, depending where their tumour was, a degree of permanency to the dry mouth. But we have big salivary glands that are the things that produce our saliva, and we want to avoid those where possible, where it's safe to avoid them without avoiding the tumour, because of course we don't want to avoid the tumour. And the other things are important are the dose to the jawbone. So we know that in the long term there can be significant problems if there's a high dose to the jawbone. Also to the swallowing muscles, and they're really critical as to how people in the long term, people like yourself that have had a high dose of radiation, what they can eat, how much enjoyment or how much trouble they can have just with that, such important function of eating every day, swallowing their saliva.
So are you saying that a key area of innovation is the increased precision of the targeting of the X-ray beam to the tumour, and also the reduction in the X-ray beam to healthy tissue?
Absolutely. And, but we're not there completely. There's still dose that's given to areas, a lower dose, and getting the X-rays in. There's a lower dose to some of these areas, and we'd like to bring those down further. An area that I see that we'll be moving towards is where each day the actual area getting treatment is that the patient first has a scan on a machine like this, or there's a new machine called where there's an MRI scanner attached to the linear accelerator, where it can actually visualise how big the tumour is on that day and what shape it is, and actually create a treatment plan for that patient on that day. Whereas at present, we start with a treatment plan, and we will change it if there are significant changes in a patient's anatomy. But on the whole, what we start with is what we end with in terms of what we're treating.
So an area of innovation that's occurring right now, because as I understand it, St Vincent's Hospital is going to launch an MR-Linac this year. That's an area that's already begun for some cancers, but when do you hope it might be able to help head and neck cancer patients?
There's already a spot for it, and that's those patients who come back having previously had radiotherapy and need even higher precision to a small area. I think that's a place for them. The MR-Linac treated its first patient this week, and that wasn't a head and neck cancer patient, but I think over the next 6 months we will have our first head and neck cancer patient on there. But there's still a lot of work. That's a new technology with a lot of work to do to further develop it to the point where it would be the standard treatment machine for a head and neck cancer patient. At present, really the key treatment is that delivered by this machine.
I want to ask you more about side effects and the possibility of reducing them, or even helping people who have side effects now. But first of all, I have to ask you about the mask that's behind you. Do you mind just showing it to us and explaining why it is so important now?
So this is a rigid plastic mask. There is some movement in it for patients, and it does have cutout around the mouth. It is obviously designed that patients can see through it and they can breathe through it, but it does keep them very still. And so we deal with millimetre accuracy. If the patient is a millimetre different to the position the treatment was planned in, then the bed needs to move that millimetre. And we can't get that accuracy without some degree of immobilisation. So I know, Julie, you like to call this the safety mask, and that's what it really is. It's about protecting the areas that are really important, protecting the eyes and those salivary glands, but at the same time, making sure that we don't miss that tumour. And with old radiotherapy, where it wasn't as accurately delivered, there was a lot more give. You're much less likely to miss the tumour if the patient moved a bit. But the problem of that radiation therapy was that it caused a lot of dose to go to areas we didn't need, and a lot of the side effects that people will read about and hear about for patients that were treated, more than a decade ago with old techniques. This mask is made, it's heated up and pulled over the patient. We recognise it's really difficult for some patients, and we have to provide them lots of support. I certainly now never get a patient to agree to radiotherapy or talk to them about radiotherapy without showing them one of these things. And then there are some very useful videos, like on the Targeting Cancer website that you've done, Julie, to help educate patients so they aren't surprised when they turn up on day one what this is about.
And in a way, what you're saying is that mask, which is made for each individual, we all have our own personal mask, is part of the price we pay for much more precise treatment and fewer side effects. It's just part of what we have to manage, and that you'll help us manage it.
That's right. And I think, but the work being done by groups like ImageX, that's the way we're going. We know already with breast cancer patients, we can now treat them without the tattoos they used to need to have to make sure they're in the right position. But it is a very significant step further to be able to take the mask away for patients that are having treatment to the head and neck or brain region.
And in another of our videos, I'll just let our audience know, we will be interviewing people about the ImageX Institute and some research they've been funded to do on an alternative technology to the mask. It's called the Remove the Mask Project. We'll also hear from a leading psychologist who will explain some of the strategies that people who do find it an anxious experience to wear the mask, some of the practical strategies that are used to help us cope. So we'll have other videos in this series that will deal with that. Let's come back to more on the future, where the future lies. You've mentioned this MRI-Linac, and that's already, taking lollipop steps, which is fantastic. We have got a video on chemotherapy and immunotherapy and some of the innovations there. Talk a little bit about the integration of radiation therapy and immunotherapy. What's on the horizon there?
So, Julie, I think actually it's the integration of surgery, radiation, and these therapies, systemic therapies as we call them, whether it's chemotherapy or immunotherapy. So as one changes, we need to change the other. Unfortunately, it takes a significant period of time to work out what the right thing to do is, because obviously we shouldn't make big changes without good clinical evidence that it's a safe thing to do. Now, really for the last decade, the talk has all been about reducing the intensity of treatment, because we know that will equate usually to better function. Obviously, the risk of doing that is that we might go too low in intensity and we actually start to impact on survival, which of course we don't want to. And so particularly with HPV positive oropharynx cancers, we know that the outcomes for those patients are better than if it was an HPV negative tumour. What we don't know is how much can we safely reduce the radiation dose, where can we omit chemotherapy, and which patients can get away with just one type of treatment, surgery or radiation, or do some patients actually need all three? And this is a really difficult problem, because we've all had patients who have HPV positive tumours who we expect will do well, yet they haven't done well despite having very intensive treatment. And so you only have to have one of those patients to really then be, make you extremely cautious about either reducing the radiation dose or omitting chemotherapy to reduce the side effects of treatment and so on, to realise that we have to tread very carefully forwards and not take leaps of faith.
And so, Dion, effectively, is there research happening now to see if it's possible to reduce some aspects of treatment to do less side effect damage, and on what sort of patients that may be the case? But it's still a research area.
Absolutely. So, there are now some studies coming out about either reduced radiation dose, those that have robotic surgery, can you omit radiotherapy afterwards based on, how big their tumour was, how many of the lymph glands were involved and so on. at this stage, it's all very early. And so it's really difficult because, of course, we want to make sure the patient has the best quality survival. But we just need to go very carefully. Now, as far as immunotherapy goes, so there are some studies happening of immunotherapy being used with radiation, post-radiation in the curative setting. At this point, most immunotherapy and the people that can access immunotherapy on the PBS in Australia are those where, unfortunately, the cancers come back and there isn't a curative treatment option. But we are going to see immunotherapy move into the curative part of treatment, but exactly how it fits and what's, which is the right drug and the right dose and so on, we're still a fair way off that.
And I should let you know, we do have in this video series an interview with 2 medical oncologists who will explain more about what Dion has just referred to. What are the common chemotherapies and what innovations are happening there, and what are some of the immunotherapies and work that's being done there, and whether it's necessary to pay for it, as some people do in order to try and give themselves a better chance of survival, or whether they can get it on the pharmaceutical benefit scheme, the PBS, which basically means we get it funded under Medicare. If you're just new to all this, there is a lot to learn, but don't worry. Cancer Council have an information and support line, 13 11 20. 13 11 20, and you can ring them. They have clinicians on the end of the phone and they will send you booklets, they'll give you information themselves, or they'll find the information that you need. And another great source of information is a website called the Beyond 5 website. So it's www.beyond5.org.au, and we'll be putting these words up around the page where you're watching this video. And that is a marvellous source of information on head and neck cancer. It has patient stories, it has amazing anatomical diagrams, so you can understand where your cancer is and what the treatment modalities are. Dion, just before I ask you a bit more about Beyond 5, because I think it's good to let people know about that, there's one last question I have, and then I'll see if there's anything else that you want to say. My question is this. We've interviewed Associate Professor Richard Gallagher, an ENT surgeon whom you work with and who's with you, the co-host of this series. And he certainly has indicated that for some patients who are getting the robotic surgery, the trans-oral robotic surgery, in some circumstances they don't require radiation as well. Is the reality that if I went to a multidisciplinary team meeting with you and Richard Gallagher and everybody else, you sort of debate and discuss in relation to each individual patient?
Absolutely, Julie. I mean, absolutely crucial, because we don't actually know at this time exactly which patient can safely go without. There are some, it's clear. A small cancer in the tonsil that hasn't gone anywhere else, that's completely cut out. No argument from me, they don't need any further treatments. But there are a number where either it's close to where it's been cut out, there are some adverse factors when the pathology doctor has looked under the microscope, has described these adverse factors that make us concerned, and then we can be not sure. And actually, it comes down to hopefully achieving consensus in that meeting when we have the pathologist there telling us exactly not just what they've written on a piece of paper, but actually where we can quiz them and ask them some more questions.
And the pathologists are the clinicians that look at the actual tumour and give you detailed information about this particular tumour in my throat.
Yes, and look, we look into a whole lot of things where the tumour's located. We've talked mainly about oropharynx cancers and so on today, but of course the head and neck region extends really from the nasal cavity in behind nasopharynx into the pharynx. It includes the mouth right down to just below the voice box. And each anatomical site, we know more about that they can behave quite differently to one of the other anatomical sites. And we talked about HPV versus the HPV positive cancers versus the non-HPV positive.
And if I could just explain for people who are new to all this, the two other main causes of cancer in your tonsils, tongue and throat can be smoking or heavy drinking. And the human papillomavirus is now coming up as another very major cause of these cancers in that area. Listen, can I just ask you, we saw right at the beginning of this video Hans Eid, a patient who's had radiation and surgery, and he was basically crying out for access to a multidisciplinary team to help beyond the 5 years because, and I've had in preparation for these videos, many emails and questions sent to me with very specific concerns about, I can't open my mouth very much after the surgery. I still don't have any saliva. I still have to use a peg tube to have my liquid food only. I could go on, dry mouth comes up a lot.
And not to mention the dental problems.
And the dental problems, and we do have an interview in our series with a very experienced dentist. So there are some people who, despite all the effort of the team, have prolonged and serious functional and side effect issues. Do you think we could increase access to rehabilitation with a multidisciplinary team? Is that a still to be done thing in this area?
Well, I think the key people that are required are those that attend multidisciplinary meetings. And so it is a point at least of access where, we can take patients along that we've seen in follow-up that have these problems. I think, though, there are a lot of challenges there. As people are longer out from treatment, we tend to see them less frequently. We don't necessarily appreciate as well, because we're seeing them less often, the troubles that they're having. And so we don't always help them navigate to where they actually need to navigate to.
What it feels like, if I may say, as a patient, is that almost like at 5 years, there's a kind of a tape in some sort of race, and we breast it. And then you're all so busy with the acutely ill people who are still in that early multi-checking phase to check they don't get recurrence, that we just get a lot less attention.
Yeah, I agree, and I think the whole survivorship space in cancer is one that there is a lot more discussion about now. The focus has not been of survivorship in head and neck cancer so much, but in fact I would argue that's where it should be, because your patients with head and neck cancer often pay close to the greatest price in terms of long-term problems related to their therapy. So not just psychological, but very significant physical problems. And we can do better with that. And I think Hans highlights that really, that people, he can be really appreciative of the care that he got. But, when it comes further down the track, accessing the system, we know how hard the healthcare system is to navigate. And navigating to the right people, especially if it turns out it's a problem that isn't one dealt with by members of that multidisciplinary meeting, but other specialists, that can be really hard to know. Who is the right person? Who is the one that's going to really say, yeah, I can see what the issue is here, and work closely with the previous treatment team to make sure that patient gets optimal care. And that's a real challenge, Julie. And look, I think, dental is part of really, is probably the biggest challenge of all of that because of the lack of funding of dental.
My goal, and we interview Associate Professor Sharon Liberali, a special needs dentist from Adelaide, in this series, and I've told her that before we both die, we have to get a special inclusion of the mouth for Medicare, for public patients, for head and neck cancer patients, because we have such particular dental needs. This is a personal passion.
Go for it, Julie.
But just before I let you go, and I'm looking forward to interviewing a very experienced speech pathologist and dietitian to look at the issues of radiation therapy treatment from their clinical perspective. In a nutshell, why should people go to www.beyond5.org.au, this Beyond 5 website? Why should both clinicians and patients and family go to that website and have a look?
You should go and have a look at Beyond 5 because it is internationally the most comprehensive website when it comes to patient information about head and neck cancer. This information, it was identified, such a resource was missing, and a huge effort has gone into this. It has hits from all over the world now. It has the cancers broken down into all the different areas. It talks about all the different treatments. It has great animations on there to explain the anatomy and what that can be done. It doesn't just deal with cancers of the lining of the mouth and head and neck region, but also salivary gland cancers and skin cancers. And so it's all in one spot, and it also has contacts that you can get to. You can see, is there a patient support group in the area that you live in? Or maybe there isn't, but there's one you can contact. And so it is a great resource for patients with head and neck cancer, and a very reliable one, because we know out there, there's a lot of sort of unreliable information. It's hard to find that one place.
Look, Dion, thank you so much. And as you can hear, Beyond 5 is a great resource for you, as is Cancer Council 13 11 20. 13 11 20, it's a free call all across Australia, and we'll put into our material around this video the number you can ring in New Zealand. So thank you for watching this program about radiation therapy, but don't go yet, because I'm about to introduce you to a speech pathologist and a dietitian in just a moment.
Head and neck cancer, treatment innovations, improving survival and quality of life. Providing up-to-date, evidence-based information for everyone in the head and neck cancer community. Presented by Julie McCrossin, a head and neck cancer survivor. Media production by Daniel Taylor at Inside IT. Celebrating World Head and Neck Cancer Day, 27th of July, 2020. Innovations in surgery, radiation therapy, chemotherapy, immunotherapy, dental care, managing distress and recovery, managing mask anxiety, remove the mask research, Aboriginal and Torres Strait Islander patients, family and community. Discussions of innovations that are improving survival and quality of life for patients with head and neck cancers. The 2020 Head and Neck Cancer video series. Presented by St Vincent's Hospital Sydney, the Kinghorn Cancer Centre and St Vincent's Private Hospital Sydney.